So we're talking about calcium channel blockers. What do those do for us? You could say the very bare minimum, they block calcium channels. Good. So what can that do for us potentially? Slow down heart rate. Good, because it works on what type of tissue in the heart? The SA, the AV node, right? Slows down nodal conduction. What will it do for, say, contractility in the heart? It'll decrease it, right? And again, we're going to talk about specific ones that will do that versus some others that do not. And then what does it do, say, on the arterial side of things? Vasodilates, good. So this is good for helping with blood pressure. So we're going to see this is good for angina. We'll talk about angina more specifically in the next section, which I believe I posted up. This is good for hypertension, arrhythmias, some cases heart failure. We'll talk about which one specifically. Even things like migraine prophylaxis. There's a lot of things that these drugs are going to be able to help us out with. And so there's two main differentiators here. There's going to be what we call the dihydropyridines. If you see DHP, that's what we're referring to, and there's going to be the non-dihydropyridines. And there's two drugs that fall into that category. It's going to be Diltiazem and Verapamil. Those act very similar to one another, and we'll talk about them and their particular actions. So just remember, there's non-DHPs and there's DHPs. The big difference between non and DHPs is that you're going to see that the non-DHPs have a lot of activity on the heart. They will also cause vasodilation. These are kind of very balanced in their actions. Here you're going to find the dihydropyridines are just focused on the vasodilation. Okay, they have no direct effect on slowing down the heart, on decreasing contractility. In fact, if I were to have a vasodilator on board that dilates the vessels, causes blood pressure to go down, what does that do to your heart rate? Go up or down? Goes up. If blood pressure is down, cardiac output wants to go up, right? Heart rate wants to go up. So actually, in some cases, you'll find that DHPs actually cause a reflex tachycardia, right? So that's an important. I look at that quite a bit. So for instance, if I'm on call for the poison center and they say, oh, a patient took an unknown cardiovascular med, we have no idea what they took. They're coming in, they have a low blood pressure and their heart rate's up. That leads me to think that, well, it's probably something that's a vasodilator, versus if it's low blood pressure and low heart rate, then it may be something that's going to be acting on both sides of the equation here, right? So these are things that I particularly look at. These are things you may see in terms of side effects for your patients, right? So anyway, so we'll talk about verapamil and diltiazem first. So these are good kind of wide-acting agents. We can use them IV, we can use them orally for more chronic management. We'll see them used for angina, hypertension, SVT. When I say supraventricular tachycardia, why does it make sense that I could use something that's slowing down nodal conduction? Because basically you have some sort of arrhythmia developing in the atria that's being transmitted too quickly down to the ventricles. Well, if I can slow that down, that allows for the ventricles to pump more efficiently, right? Do I really care that the atria are pumping that efficiently? Not really. They're not really all that important overall. The ventricles, though, are the important thing there, because for the most part, what causes most of ventricular filling during the cardiac cycle? It's just gravity, yeah. It's just gravity driving the blood from the atria down to the ventricles. The atria provide very little assistance in that. So in those cases there, you can find, even though the atria are just sitting there quivering, it's overall not a problem as long as the ventricles are still doing their thing efficiently. And so that's where you'll find, when we talk about SVTs and different drugs to treat that later on, we'll see how these are going to be useful. Anyway, so what are some adverse effects you can expect to see? Because while they are very effective, you'll see a host of side effects here. So certainly, in terms of heart rate, what do I expect to see? Be too fast, too slow? Too slow, right? So you can see things like AV block develop here, bradycardia. Imagine if you have someone who already has a poor left ventricle already, they have CHF, that could potentially worsen that. So these are not going to be great drugs to add on for patients who have CHF, because they can actually exacerbate that. It can actually put them into decompensation, end up in the hospital because of that. So you have to be really careful in terms of that. You can expect to see hypotension because of the vasodilatory sort of effects. You can also see a peripheral edema develop because of that. Again, could be a problem if you have like a CHF patient or someone with peripheral vascular disease potentially. Other things to consider as well be the nausea, vomiting, diarrhea. We see that quite a bit, but the constipation is actually going to be a big thing here. Now, why do you think you might see constipation with a calcium channel blocker? Because the smooth muscle in the GI tract can be affected similarly to the smooth muscle on the vasculature, right? So if I'm blocking calcium from coming in, I prevent that contraction from occurring. Peristalsis doesn't really occur like it's supposed to. So constipation is going to be a big side effect from these medications here, right? So one thing to keep in mind there. And certainly in terms of CNS effects, you can see some fatigue, maybe dizziness, insomnia, you know, kind of non-specific things related to usually lower blood pressure, and especially in more older patients. Like I mentioned, with most of the antihypertensives, you can see things like sexual dysfunction, so that's just a well-known sort of thing with a lot of those drugs. You know, kind of random ones like gingival hyperplasia, you know, usually good oral care, kind of keep that in check. Now, contraindications for both verapamil and diltiazem, as we'll see here, they're going to be very similar when I talk about that one specifically in a moment, is that hypotension and advanced heart block, obviously those are going to be contraindications because those will both be worsened by the non-dihydropyridines, and certainly in terms of relative contraindications, they have heart failure. This may not be a good first-line drug to put them on. Things like liver disease and GERD may be exacerbated by these drugs, right? Now, the other big thing to note with verapamil and diltiazem, they are both going to be strong CYP3A4 inhibitors. So they're strong CYP3A4 inhibitors, which means that other medications that are going to be substrates of CYP3A4 are going to be affected here, right? Have we talked about any of those recently? Statins are a big one, right? And again, patients who are on statins probably have cardiovascular disease and may also be on calcium channel blockers, right? So important things to keep in mind there, that a lot of the statins may be affected by this, like atorvastatin, simvastatin, those are very common ones, but a lot of other drugs as well can be affected by this, right? It also affects this efflux pump called puke-glycoprotein. You can kind of think about that working in conjunction with CYP3A4 to kind of keep drug levels down. If I inhibit that pump, obviously you're going to get increased levels of the drugs as well there, okay? So those are the pharmacokinetic interactions you'll see with these drugs here. The pharmacodynamic interactions that are going to be related to its actual mechanism, right? So if I were to add on, say, diltiazem plus another antihypertensive, what would you see? Well, synergistic drops in blood pressure, right? So you can see hypotension as a side effect. It could be a drug interaction you run into there, right? If I were to put them on some other medication that slow down heart rate plus diltiazem, guess what? Bradycardia is going to be more likely to be seen. So those are the dynamic interactions you're going to see as opposed to the kinetic interactions, right? Not only that, but diltiazem and verapamil we'll both see are going to actually be substrates of CYP3A4 as well. So not only do they inhibit the enzyme, but they also can be affected by other drugs that inhibit the enzyme. So just kind of keep that in mind, right? Have we talked about any other strong CYP3A4 inhibitors in the past? Like, yes, we have. Which ones? Macrolides are a big one. Fluoroquinolones actually did 1A2. They don't actually inhibit CYP3A4 specifically. Anything else? Yeah, a lot of the antifungals will, like the azole antifungals like fluconazole, ketoconazole, a lot of those will do as well, right? Because they inhibit fungal CYP enzymes, right? So they do it to us as well. Okay. Verapamil will act exactly the same as diltiazem for the most part. We'll use them in the same clinical indications. You're actually going to see the same side effects and the same sorts of interactions here. And again, it's not important that you remember whether there's 4 pluses or 2 pluses. It's not really so important for our purposes here. The general trends is what I'm looking for, right? So know that the non-DHPs are going to be good for slowing down cardiac conduction, slowing down heart rate, or contractility. Those are the good things to know about that. They'll also be vasodilatory as compared to the dihydropyridines. Same side effects, nothing really big to mention here. There's different between this and verapamil, same contraindications. You can kind of think about them interchangeably. And in fact, a lot of places, the which one you use is all dependent on like the formulary. Which one usually is whatever is cheaper, whatever the doctor more used to using, typically is what ends up on formulary there, right? Same interactions, so think about verapamil and diltiazem as both being CYP3A4 inhibitors, so those interactions are very important to think about in terms of, if you say for instance, if a patient who's on a statin, say they're on atorvastatin, and then someone adds on verapamil, what sort of side effects might be increased because of that? So you have higher atorvastatin levels, right? So what could that lead to? What kind of toxicity, right? So specifically, because toxicity won't be an answer choice on the test, right? Yeah, so myalgias, myopathies, rhabdomyolysis potentially, liver dysfunction could be worsened, right? Those are all things you'd expect to see, okay? So again, if I give you a vignette on a test and I say, patient comes in, they're experiencing these side effects because they're on this medication, they just added something else on, what would that drug most likely be? You could say something like, okay, patient comes in with myalgias, they're on atorvastatin, they just had a new drug added on, what could it be? Is it causing this interaction? Well, verapamil and diltiazem could be one of those, right? Could have said a macrolide, it could have said a antifungal, any of those would be totally reasonable answers due to that interaction, right? Because again, you might be you know, especially if you're like the primary care person, are you going to be the one prescribing every single one of the drugs the patient's receiving? No, like you may be doing some of them, but then they have specialists who are prescribing other medications, and so you may be the one that's kind of uncovering a lot of these interactions because a lot of people aren't talking to one another, and you know, so it's really important to do that med history, get a good idea of what they're specifically taking. Okay, so going and switching gears into the dihydropyridines, most of these are pretty easy to recognize because they'll have pene at the end of the name. So for instance, like very commonly, amlodipine is probably one of the most common DHPs you'll run into. Nifedipine, nicardipine. Nicardipine is actually a really good IV one that we can use as a continuous infusion to kind of titrate and control patients' blood pressure when they're elevated in the hospital setting. Most commonly used for hypertension. Sometimes it'll also be used as add-on therapy for angina, which we'll talk more about in the next section. Things like isradipine, felodipine, isodipine. Nimodipine is actually kind of interesting. Nimodipine actually helps for patients who have had a subarachnoid hemorrhage. It actually prevents cerebral vasospasm from occurring there, so it kind of keeps the blood vessels sort of in check and keeps them sort of stable after the patient's had a subarachnoid hemorrhage. So kind of interesting. For the most part, we like to use longer acting formulations. We tend to find that when you use a short acting vasodilator like one of these, it can bottom out the pressure pretty significantly. And so what kind of side effects would you expect to see if your blood pressure just like all of a sudden dropped? Maybe, yeah, syncope could definitely be the endpoint of that. Before you get to syncope, what else could happen? Dizziness, yeah, blurred vision, increased heart rate, yeah, all those things. Especially, imagine older patients, they may not have a lot of hemodynamic reserve if they're going from a lying or sitting position to standing up. What do you call that? Orthostatic hypotension can be a big side effect from some of the dihydropyridines. It won't be as big of an issue, say for instance with the non-DHPs, but certainly because the DHPs themselves are just dilating the vessels very specifically, you can definitely see a lot more of that. So in terms of adverse effects, these are going to be much worse in terms of causing peripheral edema, so especially be careful in patients with like CHF, you know, anyone's having, say, right heart failure, if they're having ascites and liver dysfunction where they're backing up a lot of fluid, this can worsen peripheral edema. I mentioned the rebound tachycardia related to that as well. You'll see here that the gynecomastia tends to be a bit worse, and also you're going to find that the constipation tends to be a bit worse with these drugs as well. So that's another thing to kind of note with that. Which makes sense because they're more specific for the blood vessels. The kind of smooth muscle makes sense that they'd be more specific with the GI smooth muscle as well, right? So some contraindications you'll notice here, bradycardia is not a contraindication. Why is that? They don't work on the heart, right? Exactly, they're not going to worsen that. However, if you have something like severe aortic stenosis, that can be a problem as well because you're dilating all those vessels, but the aorta is not able to kind of pass that blood like you need to. That can lead to really profound hypotension, hypoperfusion. So that would be a contraindication. And then any like recent MI or unstable angina, you wouldn't want to use really quick-acting, immediate-release formulations because again, you can bottom out the pressure, which may lead you to have hypoperfusion of the heart, which can kind of worsen that infarction, right? Okay, so in terms of pharmacokinetic interactions, you're going to find that the DHPs, they are substrates for CYP3A4, but they do not inhibit CYP3A4. So that's kind of the big difference in terms of interactions between the DHPs and the non-DHPs. These do not inhibit CYP3A4. Okay, they may be affected by other drugs that inhibit CYP3A4. So if I put something like chlorothromycin on top of amlodipine, you would expect to see elevated levels of that drug because you expect to see that interaction occur there because of that CYP3A4 inhibition from the macrolide. However, you do see a lot of pharmacodynamic interactions. If I were to mix this with another antihypertensive, expect the pressure to go down, right? If I were to mix this with something like a beta blocker, we'll talk about beta blockers in a little bit. Did we already talk about beta blockers? Not yet, we'll get to those. But basically, we know that beta blockers will slow down heart rate. So if I have them on a DHP that's dilating the vessels, lowering blood pressure, but they're also on a beta blocker, that kind of prevents that rebound tachycardia, and that can lead to worsened orthostatic hypotension. That can be an issue.
You said that for chlorothromycin, would that be the drug that has an increased half-life, or would
It would be the like amlodipine in that case there, right? Because that one is, so chlorothromycin would be the inhibitor, amlodipine would be the substrate, right? So it would be affected by the macrolide. Would go up. For sure. Again, this is just what I was talking about, how if you have a CYP3A4 on top of one of these, that half-life will be increased. Okay, any questions on the calcium channel blockers? Now we're kind of going over these briefly. We'll talk much more about them and how we use them in some of the upcoming sections, so don't you worry, we'll have much more details on these. Anyway, getting to beta blockers. What do beta blockers do? Very good. What does that do for us? Okay, so it can decrease heart rate. What else can that do for us? Cause some degree of vasodilation. We'll kind of talk about the mechanisms for that. It's not really a direct vasodilation, as you're going to see there. So primarily, where do we find beta receptors in the body? On the heart. What lies on the heart? Which type? Beta 1. Good. What about beta 2? Where do you find those at? The lungs. Where else do you find beta 2? It's going to be on the vasculature as well, right? So typically think about beta 1 as being stimulatory on the heart. If I increase beta 1 activation, what do you expect to see? Think fight or flight response, tachycardia, increased contractility, right? Because again, you're trying to increase cardiac output because you're trying to run away from whatever's scaring you, right? In terms of beta 2 activation on the lungs, what do we say that does? Does it constrict? It causes smooth muscle relaxation, right? Because again, if I'm in a fight or flight response, I want to relax that smooth muscle so I can breathe better, right? So I can oxygenate the muscles so I can run away, right? So beta 2 agonists we use for an asthma to help bronchodilate and relax that smooth muscle. So presumably if beta 2 receptors typically relax smooth muscle, what would that do on, say, the blood vessels? It would relax them as well, right? So you're going to find that there's sort of a balance between beta 2 receptors on the vasculature causing vasodilation, but what constricts the blood vessels? Alpha 1 activation, right? So there's a balance between those two there in order to keep the blood pressure under control. Because if you think about, like, in your fight or flight response, are you increasing blood flow to every single organ? No, right? So what's taking maybe a back seat if you're in a fight or flight response? GI tract. Like, I don't really need. That's why they tell you don't go hopping in the pool right after you get done eating, because you're going to be diverting all the blood flow away from your GI tract to work your muscles, right? And then cause cramping, right? I never listened to my mom anyway whenever she said that, but still, you get a cramp every time. So again, certain organs are going to get underperfused, certain organs will be overperfused in those cases there because you need to shunt the blood around. And that's where the balance between beta 2 and alpha activation come into play there, okay? So anyway, so what the beta blockers will do for us, as you might imagine, it will cause a competitive inhibition of the cardiac beta 1 receptors. For these purposes here, that's kind of the main action that we're going to be looking at here. And so as you might imagine, if I have someone who's on a beta blocker, exercise intolerance can be a big issue for them, right? So again, if I'm trying to, say, run away from something, but all those beta receptors are being inhibited, that epinephrine and norepi will not really be able to directly affect the heart unless you can have the exercise intolerance, which can be a problem for especially younger patients who are on beta blockers. Also, you're going to find that by blocking beta 1 receptors, you also will decrease renin release. This is the important part in terms of it affecting blood pressure. If I decrease renin, what does that decrease the production of? Angiotensin 2. And angiotensin 2, does that constrict or dilate vessels? Constricts them, right? So by decreasing angiotensin 2, you're causing more vasodilation to occur there. And obviously we know if we block beta 2 receptors in the lungs, that can lead to indirect sort of constriction of that smooth muscle, right? So this is going to be a problem. We have to be really careful of patients who have reactive airway disease, who have asthma. You want to be careful with using beta blockers in them. At least specific beta blockers we'll talk about just a little bit, okay? A little bit later we'll talk about selective versus non-selective beta blockers, which one do you want to pick there, okay? Other things we can see is that you can find some presynaptic beta 2 receptors actually help to decrease norepi release, which can also indirectly sort of cause decreases in blood pressure, because less norepi acting on alpha 1 receptors causes less activation there. And then we'll also find that there are some CNS effects can be related, and so you tend to find this more likely with very lipophilic beta blockers. Why do you think that is? They're lipophilic, they're more easily able to get into the brain, they're more likely to cause CNS effects, okay? So you can find that it will decrease sympathetic nervous system activity from the CNS standpoint, but that can also lead to things like actual depression, right? So you may find things like altered mental status or actually nightmares in some patients with really lipophilic drugs. I'll talk about one specific example. That's why you have to be careful with using beta blockers in some elderly patients. It can actually worsen their mental status. You're like, oh, is grandpa getting more demented, or is it just the medications, right? So sometimes it's difficult to determine between the two. And then finally, it has this altered baroreflex response. What does that mean? It's a baroreflex, pressure reflex, right? So remember, if you have baroreceptors located in the vessels such that if you have low pressure and they detect that low pressure, what does that do? It stimulates cardiac output, and once you get the blood pressure back up, it'll cause vasoconstriction, right? What happens if you chronically have high blood pressure? they get reset. They get a new set point, right? If you're constantly sitting at 160 over 100, they just think that's just the new normal, right? So they'll say, okay, that's normal. If you try to deviate from that and say try to lower the blood pressure, how does the body respond? It's going to try to get it back up to where it's used to being. So one of the big benefits of using the beta blockers, they help to reset that reflex such that you can get back down to what would be considered normal, right? Your normal, presumably if you don't have hypertension, should be around 120 over 80. If you get below that, then it'll try to increase that back up to that point there, right? So this is part of what the beta blockers do, is to try to get that altered baroreflex response kind of reset. So the differences in beta blockers, there's quite a few of them, but one of the biggest differences here is going to be selectivity, meaning are they non-selective for which type of beta receptors they hit, or are they going to be selective for one particular type, okay? So we'll talk about beta-1 selective drugs, we'll talk about non-selective drugs. As a general caveat, something I use to remember which ones are which, again there will be some exceptions to this rule, just like with all rules, is that if a beta blocker starts with the letter N through Z, is typically a non-selective beta blocker. If it starts with A through M, it is most likely a cardioselective beta blocker, but we'll talk about a few notable exceptions to that. So just one thing we'll talk about, and it'll make more sense here in a few minutes. Now, in terms of other differences between them, metabolism can be an important factor there. So for instance, some of them are going to be more hepatically eliminated, some are going to be more renally eliminated. Just depends on the patient which one that might be better for. So for instance, some of them are just completely undergo renal elimination, some of them are just hepatic, sometimes they're going to be mixed between the two there. And we'll also see there's some other interesting activity that can come about from these drugs. So for instance, there's something we call intrinsic sympathomimetic activity. We won't focus too much on this here, but it's interesting that in some tissues it may have intrinsic agonist effects. It's almost kind of like an agonist-antagonist sort of activity here, to where it can actually be beneficial for someone with like heart failure or maybe bradycardia. We'll talk more about that in just a few minutes. Other things you can look at is what we call membrane stabilizing effects. This can be good for patients with arrhythmias, and we'll talk about a few instances where you can use that. Typically, you're going to find, we'll talk about antiarrhythmics specifically in sort of the last cardio section, but you'll find some beta blockers are good at helping to kind of prevent arrhythmias from occurring. And then we'll also talk about a few in the third generation of beta blockers. They're going to also provide some ancillary benefits, namely things like nitric oxide production. We know the increase in nitric oxide production does what to the vessels? It'll dilate them, very good. We'll talk about alpha-1 antagonism. If I block alpha-1 receptors, what does that do? Yeah, it causes vasodilation, very good. So we'll look at some of these different activities here, okay? So, in general, the thing I want you to mostly focus on is going to be, obviously, being able to recognize the beta blockers, right? And so how can you recognize a beta blocker? LOL, OLOL, or something like that, always be at the end of the name here. So for instance, here we have our first generation or non-selective beta blockers. Notice here, N through Z is going to be delineating the non-selective ones, right? So they'll be able to hit both beta 1 and beta 2 receptors. They'll both be able to block those receptors from activating, right? In terms of activity here, I want you to know just a couple things. So for instance here, like propranolol or pembutolol, both have high lipid solubility. So what do you know it does in terms of CNS effects? Much more likely to see those, right? So this is why you have to be careful using something like Inderol or propranolol in an elderly patient, because you can definitely end up seeing things like worsening dementia, nightmares, things like that because of the high lipid solubility. It's one thing I would note. Again, I wouldn't focus too much on this ISA activity or membrane stabilizing activity. We'll talk more about that later. But really, again, and I wouldn't memorize specific for our purposes the elimination pathway. Just know that it could vary between the different beta blockers. Okay. For the selective agents, the beta-1 selective agents, and who do you think this might be beneficial for to use a selective beta blocker? Asthmatic patients. Why? Because it doesn't block up the beta 2 receptors, right? So for instance, if I'm having asthma exacerbation, I want to use my albuterol, which is a beta 2 agonist. I don't want to be blocking up those receptors with a beta blocker, right? Otherwise it'll make that drug less effective, okay? So it's not like if I give someone a non-selective beta blocker, they're automatically going to go to an asthma exacerbation, but it will predispose them to that. It will mean that if they take an albuterol or beta 2 agonist, it will make it less effective, right? Anyway, so by using a selective beta blocker, you're going to find that you can mitigate some of that. So these would be safer in patients who have a history of asthma, right? Now, is selectivity absolute? Generally, no. If I increase my dose, you can lose selectivity. So it's not to say that these are completely safe in asthmatic patients, but they are safer, right? So you have things like atenolol, acebutolol, bisoprolol. One that we use quite a lot in the hospital setting is actually called esmolol. Notice here the brand is Brevablock, Breva meaning short. This is a nice one we use for IV continuous infusion. We can actually titrate the blood pressure quite effectively, heart rate and blood pressure, just based on titrating the dose, because that's such a short half-life. So that's kind of one thing we'll do pretty commonly there. And certainly most of you have probably heard of metoprolol before. It's a pretty common one in terms of beta-1 selectivity. Now with metoprolol, there's two different salt forms you'll find out there. There's metoprolol tartrate and there's metoprolol succinate. Anyone know the difference between the two? So yeah, one's long-acting and one's going to be short-acting. The long-acting forms will be important when we talk about CHF later on, but the nice benefit of using a long-acting formulation is what? Less frequent dosing. Yeah, you can give it one time a day instead of twice daily. It helps with compliance. The way I remember it is that metoprolol succinate, I think like a hard candy. I think you have to suck on it for a while. Succinate is a long-acting form. So think of like a butterscotch or Werther's Original or something like that. You have to suck on it for a while. That's going to be the succinate form. That's a long-acting form. The tartrate is going to be quick-acting. I don't really have a good mnemonic for that to memorize that. I was thinking like tartar sauce, but that doesn't really work for me at all. But definitely the succinate, that I can remember, right? Anyway, so then there's the third generation, and so these kind of buck the naming convention I used earlier with the A through N or A through M being the selective beta blockers here. So you just have to memorize that these are the third gen, and they do have some different activities here. So we've talked about things like betaxolol and cardiolol before. We talked about that in ophthalmology, correct? So it might be coming up on the test. Is that correct? Glaucoma on the test? Yep. Yep, should know that. And so the other two new ones we'll talk about here are going to be carvedilol and labetalol. These are good systemic third generation beta blockers here. Now note they are non-selective, so they will still carry some risk for asthmatic patients, right? But they have additional other actions here. So for instance, they have additional alpha-1 blockade, which does what to our blood pressure, we mentioned? I'll have to lower it further, right? So these have additional benefits for hypertensive patients, because not only are you lowering blood pressure through its activity on the angiotensin system, but also because you're blocking alpha-1 receptors there, right? And also we find there's some kind of ancillary benefits to things like carvedilol, antioxidant properties, anti-proliferative properties, which may kind of lead to it being a good choice. For some patients who have CHF, we'll actually find this is one of the approved ones for use in that disease state. But either of these are pretty good agents. We use labetalol IV all the time for kind of like as needed sort of treatment for high blood pressure. So if you have a patient who's coming into the hospital and they have hypertension, we can have like say PRN orders for labetalol you can use to administer to get patients' pressure under control as needed. So what are the indications we would give a beta blocker for? So hypertension, you're going to find that this is typically not going to be your first line agent for hypertension. We'll talk about some other drugs that will be first line. Yes, ma'am.
You said that the last line for generation were non-selective. One that treatment just had up for this beta selective.
Which ones? Oh yes, betaxolol will be the exception, but I don't really talk about that one because it's more ophthalmology. We don't use it systemically. Yeah, so that one I'm just mentioning them here as being a third generation, but really I want to focus on the carvedilol and labetalol. Yeah.
Could you explain again what anti-proliferative is?
Yeah, so it has to do with, when you say proliferate, it means like kind of growing of the tissue and things like that. So some people feel it may have some benefit if you're thinking about like, say a left ventricle that's being overtaxed for a long period of time, right? So you think about a CHF patient who's got that high afterload for long periods of time, they're chronically stressing out the ventricle. What happens to that ventricle? The hypertrophies, right? And it gets thick and really non-compliant, and so this is thought to maybe help out with some of that. Now again, is this going to be, a very obvious demonstrable effect? Probably not. There probably hasn't been a study to really kind of tease that out, but it's thought, at least in animal studies when they're doing this, they probably saw some of that, and so that's why they kind of listed there. So it's a potential benefit. Okay, so as I mentioned, not great for first-line treatment for hypertension. You tend to find that it is sort of limited in that respect. It's a good add-on agent. So if I had a patient who maybe was already on, say, lisinopril, or perhaps they're on hydrochlorothiazide, this may be a good add-on sort of agent. We'll talk more about specific recommendations for treatment of hypertension a little bit later on. But these work better in patients who maybe have like a high resting sympathetic level, have high catecholamines, maybe resting tachycardia. These can be beneficial for them. However, be aware though, especially in younger patients, they will complain of exercise intolerance, which makes sense because you're blocking activation of that sympathetic nervous system. Thus, you can't really perfuse the body like you normally would because the heart rate is kind of capped out to some point. However, we still use it quite a bit in the elderly. Just be aware of when you're using those more lipophilic ones, you got to be careful in terms of their mental status. And again, it kind of makes sense why you'd expect kind of the long-term sort of effects of the beta blockers to be somewhat limited here. So for instance, if we're utilizing a beta blocker, say we're adding the drug on here, we're going to look at both the acute phase and sort of the chronic phases you're going to see here. And basically what you're going to see is, and when I say MAP, what does that mean? Yes, mean arterial pressure, right? And we have CO, which is going to be our cardiac output, and then total peripheral resistance. So acutely what you're going to find when you start someone on a beta blocker is that their MAP actually doesn't change a whole lot. And you're like, well, why would that not be the case? Well, if you think about it, if you're giving a beta 1 antagonist, you're going to find that you'll drop the cardiac output because you're slowing down the heart rate and contractility, but what does the body do to respond to that? It's going to vasoconstrict, right? So your TPR actually goes up in order to account for that. So you really don't find any big benefits in blood pressure sort of immediately. But what happens with more chronic administration is that as you start to decrease Ang2 activation, as you start to decrease norepinephrine release and then you fix those baroreceptors and the reflexes, you're going to find that chronically mean arterial pressure will go down. So again, it's useful as an add-on agent, maybe not great as a first-line agent in terms of hypertension. Okay, other things we've talked about: glaucoma, how it's going to be useful for there, but also think about migraine prophylaxis. Now, one thing to note is that typically when you have migraines that are developing, a lot of it has to do with vasodilation in the CNS, causing a lot of increased pressure, which can activate things like the trigeminal nerve and whatnot, cause pain. This is actually used for prophylaxis. So acutely it can actually cause migraines in patients, but if you're using low dose and kind of gently titrate it, that can actually help to prevent migraines. We'll talk more about that in the neuro section next semester. We can, yes sir.
How does vasoconstriction cause headaches?
Well, it's the vasodilation that causes the headaches, right? So acutely, that's why beta blocker can cause migraines, but if you are using low dose beta blockers and kind of work the patient up on it, it can actually help to prevent the spasming from occurring that leads to those migraines. So basically those patients have some sort of spasm that causes the vessels to dilate, and that's what causes all that pressure. But by having a beta blocker on there chronically, it can kind of help to prevent some of that. But again, we'll focus more on that next semester there. But that could be another use. If you see someone who's on propranolol sort of daily, but they're a relatively young patient, no cardiovascular history, it could be because of migraines, right? Other things might use it for would be hyperthyroidism. They're developing thyroid toxicosis, or they have like thyroid storm. Sometimes we'll use a beta blocker to help treat that, which makes sense because patients who have hyperthyroidism, what is their cardiovascular system doing? It's usually ramped up, right? So they're tachycardic, they're hypertensive. Beta blockers can help decrease that, right? What's interesting as well is that actually we can give IV propranolol, and that prevents conversion of T4 to T3. We'll talk much more about thyroid hormone next semester. We're going to get into the endocrinology section, but just know that T3 is a more active form of thyroid hormone. T4 is more like our kind of storage sort of molecule. It's not quite as active. Okay. We also use this for angina. We'll talk much more about this specifically in the next section, but it's going to help to decrease oxygen demand by the heart, such that it allows for the heart to have a longer time until they develop some ischemia and some degree of chest pain. So it's going to be very beneficial from that standpoint by limiting heart rate, limiting cardiac output, and again, helping to lower pressure. All this is going to be very good for the angina patients. We'll typically use this in acute MI as well. We find there's mortality benefits when you use beta blockers in patients who have had an MI, mainly because it's going to help to decrease cardiac output. It's going to help to decrease oxygen demand by the heart, so that's going to be very beneficial for them. However, you have to think about it in the clinical context. Some patients with an MI, if they're coming in and they're bradycardic hypotensive, would it make sense to give a beta blocker? No, it's just going to worsen that. However, if they're coming in, they're tachycardic hypertensive with an MI, and a big STEMI, metoprolol might be a really good agent to start on them, right? So it depends on the clinical context, but typically, as soon as you can, get them on a beta blocker, and that's going to help increase their survivability there. And then, similar to the calcium channel blockers, Verapamil and Diltiazem are non-dihydropyridines. Beta blockers can also be useful for treating those supraventricular arrhythmias, because again, they're going to slow down conduction from the atria to the ventricles and help to prevent those ventricles from getting that really rapid response rate. Other things we can use it for, so again, there's a lot of different indications here for beta blockers. We can use it for acute panic attacks. Why could we do it for that? If you're being attacked by panic, why might this work? Well, think about what are the manifestations of a panic attack? Tachycardia, you're sweating, you have tremor, right? So if I had like one of you come up here and say, here, give the rest of the lecture, go for it. You probably have some trepidation with that, you probably have some anxiety. So by giving a beta blocker, and again, you can actually use beta blockers for performance anxiety, right? So if you have a issue giving a big speech, or if you needed to stand in front of a crowd and talk, you can actually use beta blockers to help with some of those symptoms there, because again, it will not necessarily mitigate that nervous feeling to some degree, but you're going to see that the heart rate won't really go up quite as much. You won't see as much sweating, you won't see as much tremor related to beta receptor activation on the skeletal muscle. All that can be really beneficial to help with that. Actually, I had some people, when I was in school, we had a class called pharmacotherapy. I don't know if I mentioned this class before to you. But basically, we'd have like a facilitator in the front of the room who was like an expert in whatever field we were talking about. So if it was cardiology, it was somebody like actually worked in the cardiac unit. And they would actually like call on us at random to stand up and answer questions about this case that we had worked up, and it was very harrowing because they would be like, okay, well, what does this study say about this? This medication would be like, it says this, and well, what kind of patients were they looking at? They were looking at these kind of patients, and they're just drill it down further and further until they got something wrong, right? Very hectic. It was not fun, and again, very nerve-wracking because you never knew when you were going to get called on. But what do some people do? They took beta blockers, right? And kind of helped out with a lot of their nervousness. Now, I did not personally like that because I thought it was performance-enhancing drugs. They were helping their grade out, but you know what? If a doctor prescribed it, that's their business, right? Anyway, I said be drug-free is the way to be, right? In order to get through school. Anyway, right, so that's another thing we can use potentially beta blockers for, because again, it helps with those sympathetic nervous system effects there, okay? Now, CHF is interesting. So normally you expect someone with CHF to have, like, say, a poor left ventricle, that have poor ejection fraction. Normally, what do you think a beta blocker would do to cardiac output for a patient with CHF? Bring it down. So does that make sense? No, it sounds like you could probably decompensate that patient if you did that. However, what we do find, and there's actually 3 beta blockers we'll use here: carvedilol, metoprolol succinate, so note that it's a long-acting form there, and then bisoprolol. We actually find that you reduce mortality by giving beta blockers to these patients. The trick is, though, is you got to start really low dose and gently titrate them up. Usually they're going to be inpatient when you start these in order to make sure that they are going to be tolerating it. Because again, you can cause an acute decompensation. We want to make sure the patients are going to be there so that we can at least monitor them. We'll talk more about CHF a little bit later on. But chronically, what you're going to find is that by decreasing that cardiac output acutely, you kind of get around that, but by decreasing the pressure, afterload goes down, you're going to be able to increase the filling time for the ventricle, so it allows them to fill better, it allows them to basically kind of increase the efficiency of the ventricles, such that you do end up seeing increased survivability for a longer period of time there. Okay, so what are the adverse effects you expect to see? Well, bronchoconstriction we mentioned, which can lead to asthma exacerbation for some patients, or at least make their beta-2 agonists a little less effective. Certainly get around that by using a beta-1 selective agent, right? So what would be an example of a beta-1 selective drug? Labetalol, not really, that's a 3rd gen. Metoprolol would be a good one. Atenolol would be a good one. Bisoprolol, right? So A through N. So again, I know you just saw the beta blockers, but kind of look at them, kind of get a feel for the names there, and you'll be able to pick those out on the test. Keep in mind the cardiodepressive effects. We've already kind of mentioned is how it can lead to things like fatigue, can worsen CHF for some patients. They're going to see bradycardia potentially. That is going to be a relative contraindication there, and can certainly induce AV block. So be aware of that. It's also interesting, as you can see, decreased or disturbed glucose metabolism here in these patients. So for instance, if you have a type 1 diabetic patient, and ultimately what's the pathophys for a type 1 diabetic patient? They don't produce insulin, right? So they basically destroy those beta cells. They cannot produce any more insulin. And so in those patients, what's interesting is that what you can find is they get hypoglycemia from the effects of a beta blocker. The reason for that is because one of the things that stimulates gluconeogenesis in the liver is beta activation, right? So if I'm blocking beta receptors in the liver, that can slow down gluconeogenesis, and that can lead to less glucose being made, less glucose in the bloodstream, hypoglycemia, right? So that's one thing we worry about the beta blockers, so those type 1 diabetic patients there. Also, it can mask the signs of hypoglycemia. So what are the signs and symptoms of hypoglycemia? ever been hangry before? I like to call it the hangry kind of reaction. They're irritable, they may be sweating, they may be shaky. A lot of that has to do with sympathetic activation, right? Because your body's detecting there's low blood sugar. Well, how's it going to get the sugar back up? Well, it needs to start to break down glycogen in the liver to produce new glucose, right? So it stimulates the sympathetic nervous system to release that from the liver. However, if those receptors are being blocked up, then you can't produce new glucose, so you're going to have hypoglycemia, but also you're masking a lot of the signs and symptoms of hypoglycemia. So they may be hypoglycemic and not even know about it, and then maybe they just drop it, they just fall out all of a sudden, right? So that's one thing to really be cautious of, is to say, hey, you know, be more wary of your, maybe do extra glucose checks, maybe just be really wary of that, make sure you eat, because sometimes they'll skip meals or something, and that can lead to some issues. Now, for hyperglycemia, it can actually be caused in type 2 diabetic patients. And so for type 2 diabetics, usually what's the problem? Can they still produce insulin? They do, but they're resistant to insulin, right? So they've had such high levels of insulin circulating around because of their high blood sugars, they get resistant to it. And so what you end up actually finding is that beta blockers can actually decrease insulin release. So even though they already have high amounts, they can decrease that, which causes the blood sugar to go up even further. So again, it can also prolong hypoglycemia, mask signs and symptoms of that, but it just makes the glucose more difficult to control. So again, another reason why this may not be a good first-line agent for, say, treatment of hypertension in, say, a diabetic patient, right? So again, these vignettes will pop up on the test, and you're saying, okay, what's the right drug for this particular patient? And you got to be able to parse that out, right? So what would be like a really good drug to start out for a hypertensive patient with diabetes we talked about maybe last week? Like an ACE inhibitor would be really good. Or that really bad cough with the ACE inhibitor, you could use an ARB instead, right? Why do we like ACE and ARBs in diabetics? Kidney protective, right? So it prevents that nephropathy from developing. Very good. Anyway, some other things you'll see here is you can see impaired peripheral circulation. So certainly by blocking those beta-2 receptors in the blood vessels, this can lead to things like Raynaud's, maybe kind of worse in some patients. You can see skeletal muscle fatigue, and then peripheral artery disease tends to get worse. So you can find intermittent claudication being more common for those patients that have existing peripheral artery disease. And then another big thing to think about is if you're chronically blocking those beta receptors, what is the response in terms of expression of those receptors? Will it go up or down? They'll upregulate because they're not being activated much. So what happens when you take away the beta blocker all of a sudden? Rebound, hypertension, and actually some patients can actually induce an MI because of that. So if you have all these extra beta-1 receptors sitting there in the heart, all of a sudden you take away the drug, guess what? All that norepi hits all those beta-1 receptors, boom, heart rate goes up, cardiac output goes up, oxygen demand goes up significantly, MI can occur there. So you have to withdraw slowly in most cases. As I mentioned with the highly lipid soluble, yes ma'am.
So if someone is prescribed a beta blocker that's not actually addressing hypertension and you want to switch it to a different medication, do you worry about losing hypertension?
Depends on how long they're on it for, you know, especially what their baseline sort of blood pressure was in the first place. So, you know, I would definitely consider doing it if they've been on it for a while. So it's like several months, you know, I would definitely consider titrating them off. Yeah. And you're monitoring the pressure, so you may like start the other med kind of low dose and then kind of cross them as you go along. As you try to wean down one, you'll kind of titrate up on the other potentially. It just depends on the situation. Yeah. As I mentioned, you can see the nightmares, vivid dreams, hallucinations. Are there any other drugs that cause really wicked dreams? Yeah, Chantix, right? So we're talking about that for smoking cessation. Very good. Again, notice the increase in lipid solubility. So using something like propranolol is going to increase the amount of symptoms you see there. And another effect, you can see some elevated triglycerides. So what are the drug interactions? For the most part, these are all going to be pharmacodynamic interactions, right? So for instance, if you're using this with the calcium channel blocker, say if I was to use metoprolol plus verapamil, what might I see? So verapamil, is that a DHP or non-DHP? Non-DHP, good. Very low heart rate, so you can see significant drops in cardiac output. So that would not be a good idea. And in general, you're never going to use a non-DHP plus beta blocker. However, what if I use a beta blocker plus something like amlodipine? Hypotension would be more likely to be seen there, right? But that could be a good a combination of drugs there. You might see that pretty often in some patients. Also, we'll talk about a drug called clonidine a little bit later on that can also cause synergistic drops in blood pressure. Also, you're going to find if you have abrupt withdrawal of something like clonidine as well, you're going to see that big spikes in blood pressure and heart rate, just like you would with the beta blocker. Okay, so any questions on the beta blockers? All right, let's do a 10-minute break. We'll come back and then continue on, hopefully finish up the section. All right, any questions? Anything at all? All right, let's continue on. Oh, yes, sir. I'm sorry? What about the first assignment? It's already posted. You guys should already turn it in, right? I'm working on that. I'm working on it. Yeah. Turns out sick kids tend to throw your grading schedule off a little bit, but they'll get over it. They're fine. They're fine. Anywho, all right. So getting into central sympatholytics. When I say sympatholytic, what do you think that means? So breaking down. Yeah, you think lysolytic, right? Sympatho, you think sympathetic nervous system. So this is stopping the sympathetic nervous system from functioning, essentially. So decreasing activation of the sympathetic nervous system. Kind of think about it like that. And so there's a couple ways that this works. One of which is called the alpha 2 receptor. So we talked about alpha 1 as being primarily responsible for a lot of causing a lot of vasoconstriction. Alpha 2 receptors actually help to decrease release of things like norepi from the sympathetic nerves. And there's also some imidazoline receptors as well that kind of do the same thing. So essentially, you're going to find here that we have drugs that are working both on alpha 2 receptors and these imidazoline receptors to help decrease sympathetic outflow. And so you can find this will have different actions in the brain here, so you can see different parts where this is going to be functional. And this actually will kind of help us to determine some of the side effects we're going to see with these medications here. So clonidine is going to be kind of the prototypical sort of central sympatholytic we're going to talk about here. We're going to see here that by decreasing the release of or decreasing the activation of the sympathetic nerves here by activating alpha 2 and imidazoline receptors here, you're going to find this is going to decrease activity, or it's going to actually increase activity here in the vagus nerve, right? So you're going to have a little bit of increased activity from the vagus nerve, which is part of the parasympathetic side of things, and it's going to be decreasing the heart rate. But more specifically, we're going to find that by decreasing these activities here, we're going to have less norepinephrine release, which means less norepi acting on the vessels. What's that going to do to the vessels? It's going to dilate them, right? So you're going to find in this case here that overall the central sympatholytics have a very good ability to lower both heart rate and blood pressure, right? What other drugs have we seen that can do that? Non-DHPs, good. What else? How about your beta blockers, right? Beta blockers can also do that chronically as well. So again, these can provide that nice balance between the two. You'll find that the central sympatholytics and non-DHPs are going to be much faster acting at that than, say, for instance, a beta blocker, but they all kind of do similar activities here, but through different mechanisms. So overall, what you're going to find, these are going to decrease your total peripheral resistance, you're going to decrease heart rate, and decrease cardiac output, okay? These are very good at being, they may not be used at first line for management of hypertension, but these are good add-on agents in a lot of cases here, okay? You're going to see that they're going to work independent of age, race, gender. They kind of work well for most people. Like I said, some patients you might find will use this as monotherapy. We'll talk about some of the side effects and why that might not be great. And again, another benefit here is no negative effects on lipids. So if you had hypercholesterolemia, that would not be a problem here. So overall, and this is the reason why we see some issues with these drugs, why some patients may not like them too much and they might want to switch to something else, is one, you're going to see some drowsiness and CNS depression, okay? Why do you think that would be? Because where's the drug working? Up here, right? And if you're decreasing activation of, say, sympathetic nerves, like norepinephrine, what does norepinephrine normally do to your level of arousal? Increases it, right? So again, I kind of have a similar central sympatholytic effect on students most of the time, where I see a lot of CNS depression and drowsiness start to initiate. Right, exactly. Anyway, so you can see that certainly this can be definitely a bigger issue, especially in some patients, younger patients as well. This can be a problem. But has anyone seen the drug clonidine ever used for anything other than hypertension? Not sleep necessarily because of the cardiovascular effects, but you ever seen anyone with ADHD who might be on something like clonidine? We'll mention that briefly here. We'll talk more about that in the psych section next semester here. But we'll see that actually can be useful for helping to kind of decrease overactivity in some patients. But dry mouth, sexual dysfunction, a lot of these things are going to be issues in terms of side effects being kind of problematic. They're really effective, but they kind of have that narrow therapeutic range where you kind of have to thread the needle, so to speak, to keep from getting the right therapeutic effects without causing toxicity there. This is another group, though, that will cause that abrupt withdrawal syndrome, right? In the other class that also did that, beta blockers, right? So think central sympatholytics like clonidine, guanfacine. Think beta blockers as well will have a sudden withdrawal syndrome. So as mentioned, clonidine is kind of like the very most common one you're going to see here. Again, you're going to get this interesting effect where acutely, especially if you have, like, we see this sometimes if kids get into, say, clonidine, patch or something like that, they can actually find acute pressor response. When I say pressor, basically means you're going to cause vasoconstriction. So actually acutely, you can find this will have some causes to increase blood pressure, but then afterwards they kind of bottom out from the central sort of effects here. And so other things you're going to find is it also can increase blood sugar levels slightly, mainly because it inhibits insulin secretion, mainly due to the effects it has on decreasing the decreasing sympathetic activation on those beta receptors. Now, other benefits here will also decrease ADH secretion. Now, normally ADH does what to our pressure? Normally increases it, right? Because when it's vasoconstrictive, but also helps to retain more fluid from the kidneys there. So that is another mention here. However, because of that effect there, it does cause some degree of sodium retention, and so oftentimes we'll give it along with a diuretic, usually like a low-dose thiazide diuretic, and it helps to prevent some of that, which can be very beneficial there. Actually, what I'll tell you, we use clonidine all the time over at Nemours. We actually use it via a different route and a different purpose here, and you'll actually find that it actually provides some analgesic activity. I say analgesia, I just mean pain relief, yeah. So what we'll actually do is we will give this along with something like an opioid, like fentanyl or something like that, or maybe even an anesthetic agent, and a lot of our anesthesiologists will actually use this as an epidural. And clonidine actually helps to activate some of the opioid receptors in the spinal column and helps to prevent that sensation of pain from ever reaching the CNS. So if you just got out of surgery, we actually do this all the time for kids who are having they have scoliosis surgery, where basically having all this hardware put in to basically straighten out their backs. And if you ever see, like, I watched a GIF the other day of the actual surgery. It was like a computer model actually going through it, and it looks horrific. And I'm just like, oh gosh, give these kids more pain meds because of all the hardware and screws and drilling and all kinds of stuff you got to do. It looks horrible. But basically, we can give this to them via the epidural, and actually helps to decrease their overall need for pain medication, right? So it can be opioid sparing in those cases there, which is a nice benefit. And actually sometimes we'll use it to blunt the effects of opioid withdrawal, as that last point there mentioned on the slide. So for instance, if I have a kid with neonatal abstinence syndrome, anyone ever heard of that? Probably mentioned it before. What is that? Yeah, so the mom is using, say, opioids throughout the pregnancy, and then the baby comes out, and all of a sudden they're not getting their fix anymore, so to speak. They start to undergo withdrawal. We'll actually give them clonidine to help to decrease some of those withdrawal symptoms, right? So that's another way we'll actually use the medication there. So as I mentioned, withdrawal effects from this drug can be pretty severe, so you got to wean off of it slowly. You can also see some, sexual dysfunction. You can see bradycardia, orthostatic hypotension. These are all things you can expect to see with clonidine. Similar to clonidine is going to be another drug called guanfacine. And so usually 10X is a common brand name as an antihypertensive. You'll also see this used under a different brand name called Intuniv. Never heard of that for like ADHD perhaps? Sometimes I have like people like some extensive history, like kids with ADHD, but Intuniv is another one. It's a long-acting form of guanfacine. And so again, why do you think this would work for a kid with ADHD? Kind of calm it down a little bit, right? So, and sometimes what I'll actually see, and again, I don't advocate for polypharmacy, but sometimes what I'll see is that kids will be on a stimulant in the morning time, and they'll be on one of these depressants at nighttime to help kind of get them calmed down and get ready for bedtime, right? Again, that is something I see quite commonly, in fact, where they'll be on something like Ritalin in the morning time, and they'll be on clonidine or guanfacine at nighttime in order to help kind of get them ready for sleep. So again, this is something you'll see pretty common practice there. Same side effects as you would see with clonidine. Just be aware of that. Again, maybe a little less sedation with guanfacine, which may be good for some kids, but it just depends. Another drug that's going to be good, and this one is not really a central sympatholytic. This is going to be more of a kind of good general purpose vasodilator. This one's called hydralazine, and so this is actually causing direct vasodilation of the vessels here. Again, we don't have the full mechanism. Probably has something to do with that nitric oxide pathway, or maybe interfering with some calcium movements, maybe like a calcium channel blocker, right? But it's a really good vasodilator. And so this is actually a good one we'll see used in the hospital quite frequently for like an as-needed basis here. So a lot of patients are not going to be on this chronically for hypertension, but if they're in the hospital and they have like an as-needed order, say if they get a systolic blood pressure above a certain threshold, then the nurse will have orders to go ahead and administer this medication in order to get the blood pressure under control. And so what's interesting though is that this drug undergoes what we call acetylation. Now I don't know if we've talked about this pathway before, but this is an important one for us. Few select drugs, and we'll talk about another one of these when we get to the antiarrhythmic section later on. But essentially, some people are going to be fast acetylators, some people are going to be slow acetylators, and this is the pathway that metabolizes the drug. So if I have someone who's a fast acetylator, what do you think it does to the half-life of the drug? It would decrease it, right? So overall, what do you think my overall dose would need to be for those patients? probably higher, right, in order to get the effect. So if I were to give a standard dose of hydralazine to a patient, it really wasn't working as well as I was expecting, then perhaps they're a fast acetylator. On the flip side of that, they're a slow acetylator, what would happen? They'd have prolonged half-life, they'd have more kind of pronounced effects from the drug, and I may need to give a lower dose, right? What's actually really interesting with the hydralazine, though, it causes this lupus-like syndrome. There's a few drugs that do this, and this is going to be more prominent with Caucasian females. For whatever reason, they tend to be more susceptible to this, especially long-term use. They're on high doses or if they're slow acetylators. And basically, they have this lupus-like syndrome where they can come in like malaise, fatigue, but they also can develop that butterfly-like rash, which is pretty particular with lupus, right? So again, if you ever, and this is like an easy board-style question that might pop up on the pants, comes in, patient's on antihypertensive, and they come with this butterfly-like rash, it's probably going to be hydralazine, right? So it's a very common one to think about there, and it's mainly because they're a slow acetylator, okay? Anyway, so those are the common things. Now again, with vasodilators, you expect to see things like flushing, dizziness, headache associated with that. Again, those are very common side effects of hydralazine.
Can you test it for like a fast or slow?
That you potentially could test for is not done commonly because again, it's only a select number of drugs that it will be pertinent for, and it's not common enough of an interaction. Now, back in the day, let's say back in the day, it's probably still done to some degree, but like when warfarin's used more commonly, nowadays you have the new anticoagulants, which we'll talk about later on, that work on, they don't require as much monitoring, but there's a lot of pharmacogenetic interactions that affected warfarin as a blood thinner. We'd actually test for that because basically if you need to be on oral blood thinner, like warfarin was it for a long time. Nowadays there's some alternatives there, but for the acetylation, we just doesn't make sense to test for it in a lot of cases. So anyway, so patients who are going to be contraindicated to this, they have coronary artery disease, mainly because that vasodilation can cause cerebral cardiovascular hypoperfusion. You be careful with that. If they have ischemia, again, this can worsen those effects there. So be careful with that case. Again, another issue here is they can turn the stools black. I always mention anytime you change a patient's urine or stool color, because again, that can be pretty problematic for them. So again, if you think black stool, what do you think of? Upper GI bleed, right? So again, you want to make them sure they know, hey, it's actually just the medication that's doing that. And you don't want to know any other medications that cause the stool to turn black? So iron products can do that. Pepto-Bismol can do that, right? So we'll talk more about those later on as we get to the individual sections. Anyway, so what do we do for hypertension? So those are the main antihypertensive medications we're going to talk about for now. How do we manage these patients here, right? And so again, you may find that the recommendations will change as time goes on. So it may be based on certain disease states, it may be based off of certain numbers you're going to be trying to reach there. In general, around 130/80 or less tends to be a pretty good number for a lot of patients there. So in terms of what drugs you're going to use to start out with for your patients, it can depend on some of their history, right? So for instance, we tend to find that black patients tend to, either with or without diabetes, they respond better if you start them off on either a thiazide or if you start them off on a calcium channel blocker. So depending on their history, say they have a history of AFib, what kind of drug would you want to start them out on? So that AFib, maybe they want to be on something like a non-dihydropyridine, right? Verapamil or something could be good for both their hypertension and also good to help with controlling down that rate for the AFib, right? We'll talk more about AFib a little bit later on, but give me one thing to consider. Or if they were, say, a black patient with diabetes, you want to start them off on antihypertensive, maybe a diuretic would be a good choice for that patient there. Although, though, if they had diabetes, what other drug class would you think of? ACE inhibitors, right? So again, you gotta have to think about what's going to be the more sort of the more compelling indication there. And in that case, if they had a history of diabetes, I'd probably start off with an ACE inhibitor, or just do the combination. You could do something like lisinopril plus, what's a good thiazide we could use? Hydrochlorothiazide, right? And that's a very common combo drug you'll find out there is going to be the mixture of those two. I think I should put that on your homework assignment, right? If you've looked at the homework assignment, perhaps it's on there. Anyway, and again, for most patients, you're going to start with monotherapy and then add on as needed there. Now, if you have a non-black population with or without diabetes, again, you can kind of start with whatever you want. It's just that in black patients, we've found that they respond a little bit better to calcium channel blockers and or thiazides. But for everyone else, you can kind of start off with thiazides, calcium channel blockers, ACE inhibitors, ARBs. Any of those are going to be totally fine for those patients there. If they do have chronic kidney disease, you probably want to start off with either an ACE or an ARB. Mainly because, again, they can have some kidney protective effects there. However, a patient with chronic kidney disease, do they have any electrolyte disturbances you want to worry about? Answer to that is yes. You really want to worry about their potassium. So what happens if I add on an ACE inhibitor? it's gonna go up, right? So you really got to watch out for those potassiums. I guarantee you there's at least gonna be one question on the test saying which one of these patient comes in with this potassium level, which one of these drugs is contraindicated, or which one of these drugs can help this problem, whatever the case may be. So you got to know what drugs are going to be affecting your potassium and how it's going to affect your potassium, right? So if I give you something like a loop diuretic, what does that do to your potassium levels? Drops it, right? If I give something like spironolactone, it's going to increase it. If I give you indapamide, ooh, what's that one? So that's actually a thiazide diuretic. It doesn't follow the naming convention, but thiazides would do what? Decrease, right? So again, you got to know the drugs and how they're going to be affecting your electrolytes. Now, why do I care so much about potassium? Who cares? You can kill somebody with bad levels of potassium, especially hyperkalemia. If you're adding on things like ACE inhibitor and spironolactone, not really taking into account what the potassium levels, you can really kill someone, right? It's not a common thing, but something that's like a big emergency. They come in, say the potassium comes in, they're 7 or 8 in the ER. That's a big deal, right? We gotta treat that patient pretty aggressively to get that under control. Anyway, again, usually if their blood pressure is not under control within a month or so, then you consider increasing the dose or maybe picking a drug from a different class there, right? Now, I would not want to use an ACE inhibitor and an ARB at the same time because, again, they're working through the same mechanism. That wouldn't really make a whole lot of sense. Similarly, I would not want to use a beta blocker plus a non-DHP together. Why is that? Too big a risk for the bradycardia, decrease in cardiac output. Would not want to use that combo together, okay? So any questions on that? Now, we covered a lot of those drugs, and we'll see that they get used for a lot of other indications, as we'll get into in the next section here. And so frequently, when you're managing a patient's hypertension, you're not just thinking about what drug is best for that hypertension. You're generally managing a lot of their other conditions, like do they have CHF, do they have previous MI, do they have angina? You're kind of picking drugs based off of that, and then you'll kind of, as a side benefit, get all the blood pressure management under control as well. All right, so that'll make more sense as we get into it. So let's go to the next section, which is part 3. Any questions before I continue on? Again, the stuff at the end of this lecture is going to be the end of the test material, FYI. Yes, ma'am.
I guess, like, is there any physiologic reason why you'd say, like, black can treat this one? I mean, if you have a patient that's half black, which medication can I use?
Yeah, that can be tough. And again, every patient may interact a little differently, right? So the reason proposed for that is that they find that black patients tend to be more what they call salt retentive, meaning they end up holding on to more salt in the vessels there, which causes that thickening, right? Because again, they get waterlogged, so to speak, so they end up getting a decrease in that diameter of the vessel there. So by using something like a thiazide diuretic, you can help to get rid of that extra sodium and water, and that causes the vessel to kind of dilate back out and get a bigger diameter, essentially. So maybe if I had a patient who was, was of mixed lineage, maybe we could decide, try the thiazide first, see how that works for them. If it doesn't work well, then switch it up, right? So it's just going to be very much sort of individual trials for individual patients.
Just as follow-up too, so if you say non-black, is that implications or like other...
Yeah, that's how the guidelines sort of...
Were they part of the study too? Or?
It depends on what the guidelines are pulling from. I've not done the deep dive onto what the AHA has actually gone through and pulled other studies from, but that's kind of how they break down the patients there. Yeah. And again, if you had to imagine if it was a lot of large U.S.-based population, U.S. studies, you might imagine what the cultural breakdown might be, right? So again, usually like Hispanics get kind of lumped in with Caucasians a lot of times like that, and especially for those type of studies, I don't know what percentage of it might have been Asian. It's hard to really say, but it certainly, if you're looking at like maybe other countries' guidelines, maybe that would give you some more indications since it might be more relevant to that particular population. I think you were next.
So another class we had, they gave us a rule of thumb, start with a diuretic and then add on or switch to another class. Is that a good way of thinking, or?
Well, if you think about it, it's probably not a bad way to start it, right? So again, if you think about the side effects, if I start someone off on 25 or 50 of HCTZ, for instance, there's not a ton of side effects really associated with it, right? Most patients are going to respond pretty well to that, and there's not going to be a lot of downsides to it. Also, it's like cheap as dirt. It's been around for forever, right? So again, that does not make it makes good sense to use that as maybe a first-line agent there. Now, is it going to be effective for every single patient you run into? Maybe not, right? But that's why they mentioned either you can try to maybe add on another agent or maybe switch over to another class, something like that. But imagine if your patient comes in and if they have diabetes, though, again, the diabetes is going to be more that compelling indication to start off on an ACE inhibitor, right? Because I wanted the kidney protective effects. So I'm going to go with monotherapy. I'm going to go with the ACE inhibitor over that diuretic. So oftentimes you got to look at their concomitant medical history to see what other things are maybe leading you to picking a different class of drug. But if I had like a standard hypertensive patient with no other past medical history, thiazide would be totally great, right? Now, would I start them on a loop diuretic? If they're edematous, yes, but I would not use it for.
Did anybody drop a $20 bill yet?
I think I did. Oh boy.
Oh, there it is.
Go to the candy fund. This is actually a social experiment to see which one of us is going to be most dishonest and grab it first. Anywho, so essentially, so again, loop diuretics probably not good for like just hypertension management overall, like unless they were edematous. So again, if you just had like a normal, like say 38-year-old dude walking in, no past medical history, he's just hypertensive, a loop diuretic I would not use for that patient, right? Spironolactone I would not use for that patient, but thiazide, yeah, that'd be a reasonable choice there. So when you say diuretic, that's usually what we're referring to in terms of hypertension management, right?
Have they fixed, because you were talking about the angiotensin receptor blockers and the recalls, have they fixed those?
I haven't followed that closely. I know they switched a lot of patients over to another agent, so it's not all the ARBs. It was specifically, I think, like valsartan was the one that got most affected, and so I think a lot of patients got switched over to a different one, right? I'm sure it was good for like whoever stock they had of those particular agents, but yeah, that was certainly. I'm not sure if they fixed it or if it's still recalled.
Okay.
Any other questions? All right, continuing on. Let's talk about angina. Getting into that specifically. So, what is angina? Chest pain, okay. Why do we get that chest pain? Many reasons? What's the main reason? Yeah, the heart is working either too hard or we're not giving enough oxygen, right? So there's an imbalance between O2 supply and O2 demand here, right? I always remember, and again, some people say angina, some people say angina, but it's funny, I think the first class I had here, I said angina, and someone's like, why do you say that? We say angina. And I was like, well, that's just how I've always said it. And they're like, well, only you say that and the cardiology person say that. And I go, well, wouldn't you listen to the cardiology guy? Like, oh yeah, I guess so. Just like I say tinnitus, it's because I actually talked to an audiologist. I had like a neighbor one time who was an audiologist. And I say, what do you say, tinnitus or tinnitus? He goes, I say tinnitus. And I go, that's what I'm going to say from now on. So listen and respect your people that know more than you, right? Anyway, so generally speaking, you're going to find angina is going to be this manifestation of ischemic heart disease, right? So we're having an imbalance between how much oxygen we're getting to the heart versus how much it's actually requiring there, right? And so a lot of times this gets as a result of atherosclerosis, right? So we're blocking up those vessels, preventing them from getting enough blood flow of oxygen-rich blood there, right? Which can lead up to, we have like stable angina, which stable just means what? It means if they rest, the symptoms go away. If it's unstable angina, they have symptoms at rest, right? That's usually much more grim sort of indicator there, which leads up to getting your MIs, right? Which can lead up to sudden cardiac death, can lead to chronic stable angina. A lot of things can lead out of that. And again, this is just the manifestation of that ischemia, is that chest pain we're getting there. Now again, is every person walks in with chest pain, is that angina? That could be musculoskeletal, it could be a lot of different things. It could be a PE they're manifesting with. So again, that's why you have to have a wide differential when a patient shows up, especially the first time they have chest pain, so that what the heck is it actually? And again, asking like what makes it better, what makes it worse, oftentimes can help you to kind of clear up the picture a little bit. So anyway, so what are some things that increase the demand of oxygen by the heart? Yeah, so anything that increases how hard it's working, right? So if there's increased afterload, it's pumping against, right? Increased resistance. That will cause it to work harder, right? What else? Right, so that's an issue of afterload for sure. Hypertrophy, perhaps, yeah, maybe that increased tissue might actually require some extra oxygen. And just heart rate in general, right? Is the heart beating more is going to require more oxygen, right? So that's going to be in terms of the demand side of things. How about the supply? What's going to affect that? Yeah, so if we're having a blockage of a vessel, that can certainly affect it. What else? Not directly. We won't really mention that too much here, but it has to do with how dilated or constricted the vessels are. So for instance, if a patient is doing a bunch of cocaine, right? So if you have someone who comes in, they're smoking crack, and they develop chest pain, why do you think that would be? What does cocaine normally do to your blood pressure? They cause vasoconstriction, right? So they develop cocaine chest pain, we call it crack chest pain, because they have constricted a lot of those vessels. In fact, I mean, if you work like downtown Jacksonville, you're going to see that all day and night if you go into the ER, because again, a lot of those patients will then, they'll be out there smoking crack, and then they'll come in because they have chest pain because of that. And so you got to rule out, okay, well, is it actual MI? Is it due to coronary artery disease? Sometimes it's a combination of the two. It can be a lot of things there. But again, how constricted or dilated the vessels can also play a role here, right? Not only that, but imagine if you have like profound hypotension. What will that do to perfusion to the heart? That'll decrease it as well, right? So again, if you don't have enough pressure in the system to actually get the blood to the coronary vessels, that can also lead to it as well, right? So again, we're going to look at the issues of heart rate. We'll look at issues of contractility, how it can affect that, and not only that, but also systolic wall tension, right? So again, how much tension is there actually in the ventricle itself can also be affected by this. Now, you'll see it's both a factor of preload and afterload. When I say afterload, what does that mean? So what the heart is pumping against, so how high the pressure is on the arterial side, and then what's preload? How much volume is coming back to the heart, right? So again, if you have a lot of, like I say, edematous conditions, preload might be quite high because you have a lot of fluid coming back from the pulmonary side of things back into that left ventricle, right? So anyway, so we're going to see that there's things we can do to affect both sides of this that can affect our oxygen demand by the heart. So for instance, if I have someone who's like really edematous, and they got a lot of high amount of preload, what can I do to get rid of that? I can use a diuretic, right? And I'll actually have to decrease that wall tension, right? Can maybe decrease some of the oxygen demand by the heart, just as an example. But certainly when you're looking at the actual supply of blood, you can find that, normally here as the diameter gets smaller and smaller, you're able to deliver a lot less blood, and this is when we get into issues here, right? So this is where you're going to see increasing grades of angina develop because you're delivering less oxygen-rich blood to that tissue. So again, you'll see that angina is this latent manifestation of ischemia. Again, it can occur with any degree of stenosis. Now, there's one type of angina I won't talk about too much, but it actually can occur in younger patients that have no degree of stenosis. Have you heard of like a variant angina or Prinzmetal angina? That's a case where you just have really spastic vessels that can lead to chest pain, even though the vessels are wide and clear if you were to, say, do a cath on those patients. Typically, you're going to find that when you have severe stenosis at greater than 90% of the vessel, that's when you get virtually like no flow. That's when you're really a big risk for developing MI, right? So what are our goals? We're dealing with these patients. Because again, what's the main manifestation of angina? When did they have angina? With activity, right? So if they're doing something, they're working out in the yard, and they can only do it for a couple minutes because then they get chest pain, right? Those are going to be things that we want to try to improve. So relieve their acute symptoms, and then hopefully prevent symptoms from occurring there, right? So we're going to try to increase their time to chest pain, essentially by using some of these medications. And just like for, say, asthma, where we have acute treatments to decrease an asthma or to fix an asthma exacerbation, and then control our medications, same thing's going to happen here, right? So I have medications that are good for a quick fix for chest pain, and then some things that prevent chest pain from occurring, okay? So we can either decrease the O2 demand, or we can increase the supply of O2 to the heart. There's going to be two main ways we can do that. So for instance, just knowing what we know about, say, beta blockers, what do you think that would do? Demand or supply? More so on the demand side of things, because you're decreasing heart rate, decreasing contractility, thus you decrease O2 demand by the heart, right? What if I were to say give them a dihydropyridine calcium channel blocker? That's on the supply side of things, because you're opening up those vessels that allow for more blood flow to the heart, right? How about a non-DHP? A little bit of both, right? So again, depending on what the other clinical indicators are, why the patients might need some of these drugs, we'll look to see how they can be used for these purposes here. Now again, what can we do to maybe help stabilize some of those atherosclerotic plaques? What other kind of medications have we talked about that helps with that? Statins are also going to be really important for these patients as well, right? And then also modifying any reversible risk factors. So again, we get them more active, fix their diet, all those kind of things would be very beneficial. Certainly, the best thing you could do is just to open up the vessels themselves, right? So if the issue is atherosclerosis causing stenosis in those vessels, then put in the Roto-Rooter team, right? And just go in there and clear those things out, maybe a stent placement, cabbage, whatever you need, right? They can do that. But we're going to focus on the pharmacotherapy because this is what the class is. And so we'll look at anti-anginal drugs, and then we'll look a little bit at vasculoprotective drugs. So like your statins, your ACE inhibitors, and your antiplatelet drugs, okay? So looking at things that will work on decreasing heart rate, contractility, and systolic wall tension, these are going to be your calcium channel blockers, your nitrates, and your beta blockers. Note, we've already talked a lot about calcium channel blockers and beta blockers, so I don't have to go over all those again. We'll talk about how they're used in angina. The nitrates will be a new class for us. And then for increasing coronary blood flow, you're going to find calcium channel blockers, nitrates, and then things like aspirin and clopidogrel. Towards the end, we'll get into more anticoagulant drugs, definitely not for this test, but certainly for the last one. So our antianginals will help to improve exercise capacity. They'll be able to do more before they develop chest pain here. Hopefully reduce some of these exercise-induced like ST segment changes here. And you're going to find that things that can help decrease the frequency of symptoms include our beta blockers, calcium channel blockers, and our nitrates. And again, how do you grade angina? Well, it's based on how much activity you can do before you develop symptoms here, right? So for instance, I guess all of us technically have grade 1 angina to some degree, right? Because we have no symptoms either at rest or with activity. But certainly as it gets more and more sort of limiting in terms of their activities, you see you have higher grades of angina. So looking at the beta blockers first, we can see what their effects are going to be in terms of demand and what their effects are going to be in terms of supply. So what do you notice about supply? They don't really do much, right? Beta blockers are not helpful from that standpoint. But what they do is they will decrease heart rate, contractility. They'll decrease afterload by affecting systolic blood pressure, and they'll also help to increase LV volume. Okay. So these are typically going to be first line for these patients here. And actually, what you find, especially for any patients with like previous MI, or if they have CHF, beta blockers are like mandatory therapy, right? So patients need to be on beta blockers if they have angina, MI, CHF, they need to be on a beta blocker, right? These are going to be good for patients who also have other concomitant disease states, things like supraventricular arrhythmias, like AFib. If they have heart failure, if they have hypertension, anxiety, these could all be really good drugs for those patients there. In general, you're probably going to go with a beta-1 selective agent if they have any history of reactive airway disease, as we've already mentioned. But certainly, if they don't have that preclusion, you can go with like a third-generation agent, a non-selective. Any of those are totally fine, right? So what are your contraindications to a beta blocker? Well, asthma for, say, a non-selective drug. What else? They already have a slow heart rate, their blood pressure is already low, those all make sense, right? CHF, if they're in a decompensated state, definitely don't want to start that. And again, we know the precautions based off what we've already talked about there, right? We know the adverse reactions, mainly hypotension, bradycardia, so be careful if you're adding this on and they're on other antihypertensives. You may need to titrate the doses a little bit there to try to make sure you're not going to bottom them out from that standpoint, right? And again, remember, why do we avoid rapid discontinuation? Yeah, that rebound hypertension due to upregulation of those receptors there, right?
So when would you use it for heart failure if it's contraindicated for heart failure?
So if they're decompensated, you don't want to use it for those patients. But in general, if you have a patient who's at a stable state with their heart failure, and we'll talk more about this next time, if they're at a stable state, and you can initiate very low dose beta blockers and gently titrate them up, and again, it's carvedilol, long-acting metoprolol succinate, and then bisoprolol are the three main ones. You see by weaning them up on that dose, kind of titrating them up, that will prevent them from having a decompensation and will increase their quantity of life, decrease mortality, right? So looking at the calcium channel blockers, you see that we'll use these differently, right? If we're using DHPs versus non-DHPs. So again, what do you think non-DHPs will do to oxygen demand? They'll decrease it, right? Because they're decreasing heart rate and contractility, systolic blood pressure, all those good things. You notice here from a dihydropyridine standpoint, why would you see an increase in heart rate? It's that rebound effect because of the vasodilation, which that sounds counterintuitive, right? Why do I want to increase heart rate if I have a patient with angina? Couldn't that worsen it? Potentially, right? So you'll typically find that the DHPs are going to be add-on therapy. Most patients will not start off with a DHP for angina, but say for instance they're on a beta blocker and they're still having some symptoms, maybe they're still a little hypertensive, you can add on a calcium channel blocker, a DHP, and that would be reasonable therapy, a reasonable combo therapy there, right? Now, if I had them on Verapamil, would I ever start them on amlodipine too? No, you typically do not mix DHPs and non-DHPs, okay? Too much calcium inhibition there. Now, in terms of supply side of things, you'll find especially the DHPs are pretty good at this. One, they can cause some mild dilation around some of the fixed areas of stenosis. If they're really kind of very stiff vessels, you can't really do a lot about that, but some of the surrounding areas can be fixed. And then also can help with the relief of vasospasm if that's also a component of their disease. Yes, ma'am. Sideways arrow either means it does not do anything or it may cause a slight decrease. So sideways just means really no effect. So mostly on the no effect side of things. And again, breaking them down into their individual components, again, looking at the non-DHPs versus the DHPs, again, we've seen similar pictures to this. Again, don't memorize the specific arrows here, but again, the general trends is what you're looking for, and I think we've already got a good handle on that from last slide set. Yeah, so, and again, I don't get into too much detail on here, but yeah, in general, if you have someone who has that prinzmetal angina, actually a dihydropyridine is the treatment for that. Basically, it prevents that vasospasm, so it might be on low dose, same amlodipine, and that helps to prevent some of that vasospasm from occurring there. Yep. Okay, so again, initially, for initial therapy, you could use a non-dihydropyridine if the patient maybe couldn't tolerate a beta blocker, right? So it could be an alternative. Say, for instance, if I have a patient with diabetes and maybe they're just really intolerant to a beta blocker, you could use a non-DHP as an alternative. But most of the patients who have angina also probably have cardiovascular disease, which means they probably need to be on a beta blocker anyway. So that's why beta blockers tend to be sort of first line there. But again, if they could not tolerate it, non-DHPs are fine. If they're on a beta blocker and need some additional benefits, some additional help, that's where the DHPs come into play. So amlodipine, nifedipine, any of those would be totally fine there, okay? And we'll also see where our long-acting nitrates will come into play in just a little bit. Now, given our contraindications, especially if you have, like, say, Verapamil on board, what would be a contraindication to Verapamil? So a contraindication would be if they have low blood pressure, low heart rate. It's almost exactly the same as the beta blockers, right? Asthma obviously is not a concern for those patients, but again, those differences between the two there. Now, if I had a patient who was, say, for instance, taking atorvastatin, are there any issues using calcium channel blocker on those patients? Because they said they need to be on a statin. CYP inhibition, right? Which ones inhibit CYP3A4? Verapamil and Diltiazem both do it, right? So you would not want to use that combination. Which statin could I use that is not going to be affected by CYP3A4? Rosuvastatin's a good one, yeah. All right. Good things to know, right? Anyway, also you want to make sure not to use short-acting agents because, again, if you bottom out the pressure, that can be a problem because, again, that can cause cardiovascular decrease in perfusion, and that can lead to actual angina in and of itself. Again, some more contraindications here. Again, be very careful of the CYP3A4 interaction. So especially if I give you a patient with like a med list and I say, what's the next best drug to add on? If they're on atorvastatin, Verapamil would not be a good drug to add on at that point, right? It's not saying that patients can never receive that. It's probably just not the best option. That's how we get away with some of those test questions. We say, which one of these would be the best next thing to do? And he said, well, you could do that. And I said, you could, but it was not the best thing you could do, right? So that's how we get around you guys asking us pesky questions, right? Anyway, remember some of the kind of unique side effects associated with the calcium channel blockers. You get the flushing. What does it do to your GI tract, typically? Constipation tends to be pretty severe with these, right? So again, if they had constipation due to some other cause, maybe they had some dysmotility issue, or maybe they're on opioids chronically, again, this could be a problematic to add on from that standpoint, right? Okay, so let's talk about the new class of drugs here. Let's talk about the nitrates real quick. So basically what you're going to find with the nitrates is that they're working just as arterial and vasodilators, and venodilators, should say. So they work on both the arteries and the veins. And so you're going to find that they're not great from a demand side of things. They will help with the blood pressure, and they will actually decrease LV volume. And they do that by actually decreasing venous tone. And by decreasing venous tone, they can hold on to more blood, so it actually helps on the preload side of things. But the main thing we're looking for them in terms of their actions are going to be dilating the coronary arteries. They also help with vasospasm, and they might have a little bit of antithrombotic effect. But those are the main things we're looking for. So how do the nitrates work? We've kind of briefly talked about them, but essentially imagine you were looking at a coronary vessel, right? So imagine this is one of those coronary blood vessels, one of their endothelial cells, one of the smooth muscle cells, I should say. The nitrates are going to come in and will donate nitric oxide, okay? Now it's different from nitrous oxide. What does nitrous oxide do? Makes your car go fast, also makes you laugh and makes you go to sleep. It's laughing gas, right? So you may see it used for procedural sedations. So different, right? So this is nitric oxide. So basically, nitric oxide is going to be given here, and this actually stimulates production of CGMP, cyclic guanosine monophosphate. What that does eventually, again, you don't have to know all the intermediary steps, but basically it's decreasing calcium in that cell, and less calcium causes what to occur? Yeah, it causes less contraction between actin and myosin and causes relaxation to occur, so low blood pressure. Or in this case here, by dilating the coronary vessel, that means more oxygen flow to the heart, right? So that fixes the angina. One thing I will note, and this is actually a really important interaction we'll kind of talk more about in a few minutes here, has anyone ever heard of sildenafil or vardenafil, or tadalafil? What are those used for? erectile dysfunction, right? So these are like your Viagras, like sildenafil is Viagra. Now, we mention this because they actually work by inhibiting this enzyme called PDE5, or phosphodiesterase 5. And normally PDE5 breaks down cyclic GMP, right? So it kind of helps to regulate the system here. Well, if I have something that inhibits the breakdown of cyclic GMP, and I give it along with something that stimulates cyclic GMP, overall what happens to the levels of cGMP? Goes up quite a lot. And that causes, what does it do to your blood pressure? It'll bottom you out, right? So this is really important that you cannot mix nitrates plus any of these erectile dysfunction meds. Okay? Yeah, so the nitrates will stimulate cyclic GMP production, and then things like sildenafil will block the breakdown of cyclic GMP because you're inhibiting this enzyme PDE5, and thus levels of cGMP go up dramatically. That causes way less calcium in the cell, which causes way less causes way less muscle contraction. Thus, you get relaxation and hypotension. Okay. And so this is important because what's our quick-acting medication to treat angina? It's nitroglycerin, right? We give nitroglycerin as a nitrate that undergoes that process of donating nitric oxide. Now, again, the beta blockers, calcium channel blockers, those are not quick fix medications. They will not be given to fix acute chest pain. They're used to prevent symptoms. This is given to actually treat chest pain. This is like the albuterol of asthma, right? If you want to think about it in terms of analogies there. And so these can be used to either treat acute symptoms, or we may give long-acting formulations in order to prevent symptoms from occurring. We'll talk about those in a minute. But basically, what we'll do is either if a patient has acute chest pain, they'll either take a sublingual nitroglycerin, or they may use like a spray or something that will be given under the tongue. And that allows for very quick absorption of the medication into the system. And also, if you have oral absorption, what does that do to the first pass? Skips it actually, right? So you have the patient stick it under their tongue, you don't have them swallow it, right? So that way you want to bypass the first pass effect. Has pretty quick onset of action. And so what we used to do is say, okay, anytime you have chest pain, go ahead and take a dose and take it every 5 minutes, and if by the time you take the third dose you're not having any relief, go ahead and call 911. Now what's the problem with doing that? Too long, right? When you're having acute, if you're having an actual MI, time is tissue, right? So that's an extra 10-15 minutes where EMS has not been activated. So now what we'll tell them is if they'll take a dose, if their chest pain is not relieved with that first dose after 5 minutes, and then they call 911. They keep taking it every 5 minutes or so, okay? So one of the first things that EMS should do though when they come in, because EMS will also be giving them nitroglycerin, they should also ask about, hey, have you taken, well, certain patients, right? So who's going to be taking erectile dysfunction meds? Typically middle-aged to older men, right? So they'll ask them, hey, have you taken anything for erectile dysfunction? And if they say yes, they will not give them any more nitroglycerin, because what could happen? Bottom out their blood pressure, then you're supplying even less oxygen-rich blood to the heart, and thus that worsens the ischemia. Now, why do you think someone might be taking erectile dysfunction medications around nitroglycerin? Well, what causes chest pain? Physical exertion. What also takes physical exertion? I think you guys are following me, right? So again, it could be a reason why someone calls 911 because they were having sex, they have chest pain as a result of that, and thus they take their nitroglycerin, but that's a contraindication. You cannot mix nitrates plus erectile dysfunction meds, okay? Because again, you can kill someone that way potentially, or at least bottom out the pressure, can lead to worsened ischemia. Okay, so do not mix those meds together. And again, because they're direct vasodilators, they can cause pretty significant orthostatic hypotension. So make sure that your patient is like sitting or standing, but try not to kind of go between the two too frequently. Nitroglycerin itself is actually pretty unstable as far as a molecule goes. So we tell the patients keep it in the original packaging. Don't put it into like pill reminders or anything like that, because it tends to break down. And again, most of the time when we talk about expiration dates on stuff, most of the time they're bogus. Just kind of an inside pharmacy secret. Most of those are bogus. This one's legit. Like I have patients get a refill every 3 to 6 months or so to make sure it's fresh, because sometimes when they take it and their chest pain doesn't go away, it's not because their stenosis is so bad or their angina is so bad, it's mainly because the drug is not as effective.
If you're prescribing this for someone who also has a medication, do you tell them the maximum amount that should be taken so they don't themselves pass out?
I would tell them, because again, we'll talk about erectile dysfunction next semester when we get like into urology, but are those like medications you're taking every single day all the time? Generally, no. Usually, it's going to be on more of the as-needed sort of basis, right? So, for instance, like back when I remember when I was interning, like Viagra was like the main one on the market, and it was like really expensive, and insurances wouldn't cover it. And I would always have like guys would come up usually on a Friday afternoon, and they'd kind of be dressed to the nines, and they only want one pill. That's all they needed, right? So again, this is going to be something more on an ad hoc sort of basis, sort of as needed. So it would be one thing to tell them, hey, make sure you don't take this at the same time as you've taken your erectile dysfunction med. Because maybe they take it on Friday, and I wouldn't want them to take any nitro, but maybe on Tuesday or Wednesday, it'd be totally fine.
Well, I meant the nitro, is there a maximum that they could take?
Oh, no, as long as they're still having chest pain, because again, you'll find that, yeah, there's not really going to be a problem there. EMS will arrive by the time that they get to that point if they're taking too much. But certainly just one pill at a time, usually 400 micrograms or 0.4 milligrams are taking each dose. Yeah. Yes, ma'am. Go to a question. I think someone in the second row. Yes.
So if they're taking erectile dysfunction medications, is this something where you take one nitro and you bottom out, or like you tell them just don't take another one and they should be okay?
It depends on the patient, right? It depends on what the pressure is at the beginning. If they're severely hypertensive, maybe it's not going to be as big of an issue. But it just depends. The big problem is if patients are having continued chest pain, EMS gets there, and then they hook up an IV and give IV nitro. That's where you're much more likely to see problems there, right? But still, I would tell patients if they are taking erectile dysfunction meds, don't take your nitroglycerin at the same time. If you have chest pain, just call 911, and they'll come in and kind of take care of it from there.
So what's the safe time for spraying if they've already taken the ED medications that you can give a nitro?
That's a great question. We'll talk about that next semester. Some of the different ones have different half-lives. So for instance, like tadalafil lasts the longest. Like that one can last like all weekend basically. So that one I would have a much longer time. So my Viagra, maybe you wait 18 hours or something like that. So it just depends on the agent you're dealing with. Yeah, for sure. So anyway, but make sure they're not swallowing it. Make sure they keep it underneath the tongue, and that way you go ahead and will be effective there. Okay. Now, long-acting nitrates. So I'll just kind of finish up the nitrate section, and that'll be the end of our material here. Long-acting nitrates are going to be useful not as first-line agents for prevention of anginal symptoms, but they could be used as an add-on. So maybe they're on a calcium channel blocker, a beta blocker, and you want to add something additionally to it. Maybe a long-acting nitrate would be beneficial there. And so a couple of different formulations you'll have here. You'll have isosorbide mononitrate or isosorbide dinitrate. Notice here that these are going to be lasting roughly 12 hours. The way you're going to be dosing it, you should be getting around 12 hours of activity. And then what's really important with nitrates is that you have to have a nitrate-free period. Now, as a concept we talked about in the Intro to Pharm class back in the summer, which you all probably have suppressed in your memories, though you'll have to go to therapy for someday. But we talked about the concept of tachyphylaxis. You guys remember what that meant? Basically means that even if I keep giving more drug, I don't get any additional benefits from it. Nitrates undergo that process to where if I were to give nitrates 24 hours a day, you'd find that it becomes less and less effective as time goes on, such that even if I give a big bolus dose on top of it, I wouldn't get any additional benefit. Basically, you start to run out of cofactors and things like that to make the reaction, basically it's a non-starter. So this is why you typically will find that if we're giving long-acting nitrates, they're usually going to be about 12 hours on, 12 hours off. That gives the body time to replenish itself such that when I give the nitrates again, it's going to be effective, okay? So you don't want to give them 24 hours a day. Now, what 12 hours do you think I'd want to cover with that? At nighttime or daytime? Whenever the patient is more active, right? So if I have someone who's like an ICU nurse who works overnights, she might want to take it at nighttime because that's when she's going to be more active, more likely to develop chest pain. If someone who works a day job, maybe I give it during the daytime, right? So all is going to depend on their schedule there. The other way we might give this would be a long-acting nitroglycerin, and so this is actually can either come as like a patch or it can come as an ointment. Here you'd find that you'd actually put the ointment and you'd actually dose it based off of inches. So you can maybe say like do a ½ inch or an inch, and then they'll actually spread that onto this patch here and then just slap it onto the skin, and that will allow for it to be absorbed over that 12-hour period there. This is actually really important, especially if like a healthcare provider is giving this at home. You have to make sure you wear gloves along with this. Otherwise, you're going to find that the patients might, or the people administering it may actually absorb some through the skin. Does it make sense? Because I'm putting it on the skin, which means that it gets absorbed, which can lead to things like hypotension, can also lead to bad headaches, right? Because why do you think you see headaches? Those vessels are dilating right in the CNS, causing you know, the kind of that pounding sort of effect on causing a headache there. So that's the big thing there. With any of the nitrates though, headache, flushing, reflex tachycardia, postural hypotension are all going to be a risk with these. Okay, so those are going to be really careful with. And again, remember that tachyphylaxis is a thing, so they need to have that 12-hour nitrate-free period when symptoms are least likely to occur. Okay. So if they work a day job, maybe nighttime. If they work nights, maybe daytime. Okay. In terms of contraindications, again, the biggest one is going to be if they have any sort of obstructions like stenosis, obstructive cardiomyopathies, surely, but really the concurrent phosphodiesterase inhibitors is going to be the big thing. Now, is it only going to be middle-aged men that are taking Viagra? Who else might be taking it? Do women ever take these drugs? They actually can. Children might be on these drugs. Actually, I give little girls Viagra and tadalafil all the time because it works for pulmonary hypertension. Also helps to dilate vessels, and we'll talk again more about the mechanism of the drugs later on, but they work as vasodilators, right? Which makes sense why it can help with causing an erection, get more blood flow, tissue can expand, get an erection. For the vessels on the pulmonary side of things, also dilate them and allow for better flow through the lungs. And so pulmonary hypertension might be another indication. So again, it's not just men that receive erectile dysfunction meds, it could be women too, depending on their indication, okay?
What about the side effects there?
Hmm?
In this case, like if you went to a child or something, what side effects do you see like this?
Same thing, you can see low blood pressure, flushing, all the same sort of things there. Again, I think a misnomer with the erectile dysfunction meds is like as soon as you give it, like the patient just develops an erection. It just allows for the erection to occur, right? So it's not like, because you still need some sort of stimuli from the psyche that actually caused the erection to occur in the first place, right? So anyway, so in terms of the anti-anginals, it's important to look at the comorbidity. So if they have hypertension, maybe a beta blocker is a really good agent to start with, right? Maybe using a non-DHP as an alternative. If they have diabetes, maybe a beta blocker is not a great first option for them because of the issues of glucose homeostasis. So maybe a non-DHP is a good starter for them. If they have asthma, it's a good start or a good agent. Cardioselective beta blocker, right? So something like metoprolol might be a good option, or maybe a non-DHP is a good option. So keep in mind what the first line therapies are going to be, what an alternative might be, and then which ones to avoid in those cases there, okay? So it says NCSBB, that means non-cardioselective beta blocker, okay? So kind of keep those in mind. I think we've kind of alluded to all of these already, so you're kind of aware of this. So if a patient has bradycardia or AV block, don't start them off on a non-DHP. Don't start them off on a beta blocker, right? Maybe a dihydropyridine is a good first option for those patients there. Kind of think about the context, because this is how the test questions will come up. They'll say, hey, patient comes in with this past medical history, which one of these would be a first line option? Or which one of these would be a good add-on agent to manage their angina, okay? Any questions on that? I think it's where I'm gonna cut it here. I guess just briefly, ACE inhibitors also can be really beneficial for these patients. A lot of times you have to worry about left ventricular remodeling. We mentioned that for CHF, right? How these patients will benefit from the ACE inhibitors. And then remember that in terms of combo therapy, you can add on, but make sure you use different mechanisms, okay? So make sure you're using something like, if you have a beta blocker on board, maybe a DHP is gonna be a good add-on agent for those patients, okay? If you need a third agent added on, you probably need a better workup, right? You probably need to actually go and get a cath done and actually see where the blockage is. Maybe you need a stent, maybe you need something put in, okay? Any questions on that so far? If not, I think we'll finish out there. Let me check the board if there's any questions. Everyone's here today? No questions whatsoever, and must have done a great job explaining it. So next week will be the test. It will cover, I think from glaucoma, I think is where it started. Yep, all the way up through angina. So just a slight bit of material to cover, not a big one. Yes, ma'am. I'm gonna try to make it roughly equal to match up with the time we spent on it. No guarantees, but it'll be roughly proportional. So just study everything, and you'll be fine. Any other questions before I let you go? If not, it's going to be a long form essay, critical thinking, 5-paragraph essay on the merits of interstellar travel, and then it should be good. Yes, ma'am. Yes. I don't know. What do you think? Good question. We should discuss it amongst your peers and come up with a plan.
Not homework was independent. Not homework was independent.
I think consulting with your fellow practitioners is never a bad thing. Certainly, I would not copy anyone's work directly, but being collaborative and talking it out, I think, is always a good thing. I always encourage that. No cheating, though. Don't talk to your other classes. Bad idea. Anyway, any other questions? All right, I'll see you guys next week.